Just a reminder for anyone who's in the hospital, we're actually having a virtual, what's called a hybrid grand rounds today. So, feel free to come by W13068. We have half the room booked. And this is something that we're hoping to start regularly in the fall, is moving back to a hybrid grand rounds presentation, so more of us can see each other. I just had two people in the room say long time no see, so I think that's part of the idea here. So yeah, today part of the reason we're having a hybrid grand rounds is we're having our National Inherited Metabolic Diseases meeting in Ottawa this week. Dr. Danielle Burke is one of the organizers, and one of our speakers is Dr. Jerry Vockley from Pittsburgh. So I asked him if he'd be willing to come a day early and give grand rounds here at CHEO. So I'm happy that he accepted that. So as usual, we will start with the land acknowledgement. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And whenever I read one of those, I do try to reflect on it a little bit, because otherwise it's just words. Yeah, please do so as well. So again, our presenter today is Dr. Jerry Vockley, someone I've now known for years and is a large presence in the international genetics and inherited metabolic diseases community. He is in Pittsburgh now, and that's actually partially why I invited him, is to tell us more about the Center for Rare Disease Therapeutics that he started up at UPMC. He's a Cleveland Family Endowed Pediatric Research Chair, Professor of Human Genetics, Chief of Genetic and Genomic Medicine, and the Director, as I mentioned, of the Center for Rare Disease Therapy at UPMC Children's Hospital of Pittsburgh. He did his undergraduate at Carnegie Mellon in Pittsburgh, received an MD and PhD in Medicine and Genetics from UPenn School of Medicine in Philadelphia, pediatric residency in Denver Children's Hospital, postdoc fellowship at Yale, and before taking his current position in Pittsburgh, he was the chair of medical genetics in the Mayo Clinic School of Medicine. So I won't read the rest of his bio because it is long. And just to say that, Jerry has been very invested, influential, and distinguished in the work he's done around the treatment of patients with rare disease, and especially in our area of inherited metabolic disease. But there's a lot of generalizable lessons from learning how to treat patients with these rare genetic diseases. Jerry has spanned the work that it takes from screening to diagnosis to investigation and research to basic mechanisms of disease to implementation and policy. So it's really with that rich experience that I really look forward to learning from and hearing from Jerry.
Great, thanks, Pranash, and thanks for the invitation. It's always fun to get asked to do something to talk about something that is in such an early stage of its development, because it gives you the opportunity to speculate a lot, and I like to do that. So we're going to do that here. First of all, I'm going to get rid of some stuff that's in my way. There we go. Now I can see, and hopefully I can keep this going without too much difficulty. And as you can see from the title here, we're really going to focus on how to bring care for rare diseases in a more coordinated fashion to our patients. Let's see if this works. Okay, let's try this. Yeah, it's.
we're working out a move back to hybrid with you, Jerry.
So when I do that, it's not. Yeah, I tried that. Let's try it again. There it goes. Now it's working. Okay. So they call this disclosures. I call them opportunities. And the learning objectives. And so let's start off with the most basic question. Why study rare diseases? Why do we even care about them? Well, that's because in combination, although individual rare diseases are rare, together they amount to 2 to 3% of all children born worldwide, really. About 0.5% of babies born have an inborn error of metabolism. And if you look at admission statistics to the hospitals and morbidity and mortality statistics, 40% of childhood mortality is related to a genetic disorder. Or a disorder that has a heavily genetic component to it. And depending on the season and the viruses and everything else that's going on, as high as half of kids in the hospital, in the pediatric hospital, have a condition that has a genetic component to it. This is a study that was published by in the American Journal of Human Genetics a number of years ago. And you can see that in percentage of pediatric hospital admissions, the sections 1, 2, and 3 here. See if my pointer works. You see that up there? Yeah, you can see that. So 1, 2, and 3 are excuse me, there are disorders that have some genetic component to them, either genetic or a major genetic component, and so it's a huge part of what we do, and you're going to run into this whether or not you are a geneticist. So a number of years ago now, but 6 or 7, when I first started thinking about how to bring more coordinated care to our patients with rare disorders, that I came up with this idea of a Center for Rare Disease Therapy. Now, even my own faculty was skeptical when I did this. They say, how is this different from a division of, back then we were called medical genetics? It's what we do anyway. We see rare disease patients, we diagnose them, we treat them. It's you have to acknowledge that to some extent. But in reality, I think if you look at most divisions or most programs in genetics, there's a much stronger focus historically on diagnostics and therapeutics, mostly because we didn't have much in the way of offering for therapeutics. And so is that chicken or egg? Do we not have therapeutics because we don't focus on it, or the other way around? Excuse me. So, but then once you get beyond that, this is really should be the purview of geneticists and nobody else. You start to realize that our colleagues in other disciplines are partners in taking care of these patients. And I'm not going to be treating their seizures. I'm not going to be doing their liver transplants. I'm not going to be dealing with their bowel disease. And so having a center where you identify individuals within those other disciplines who have an interest in rare diseases allows you a better cross-departmental and even across collaborations across the system. There are some real practical benefits to having something that has a name, at least in our institution. And what number? Excuse me. Grab my allergies hit in the spring, and I'm okay until I start talking. My wife says, "What's the problem?" What it does is it allows us to sort of consolidate resources that allow us to help patients. So we can dedicate staff to facilitate long distance visits and coordinate care. the United States, healthcare is it's not just about the patients, it's about the dollars, unfortunately. And so it allows us to also focus on branding and marketing services. And if you go in and you do a Google search on rare diseases, we come up pretty high because we've got a website that people do their website thing, whatever that is. Oh, thank you. Whatever that is, and let's see. So it brings us up in the visibility. The other component of it is if you can highlight efforts like this in the community, it actually allows you to attract philanthropy, the philanthropy is really important because it allows you to do things that you have no other way of funding, that are, stuff that you just can't write an NIH grant for. So let's look a little bit about at how this plays out. But what does a CRDT do? A Center for Rare Disease Therapy do? Well, it can vary, and it can and should leverage the strengths of the institution that you already have, and allow you to build out from there to improve your services for patients with rare diseases. At Children's in Pittsburgh, we have we traditionally had a very strong focus on inborn errors of metabolism. That included transplants for inborn errors of metabolism, both liver and bone marrow. And we also had there was a partner program that focused on neurodegenerative diseases, both evaluation and therapy. So we were able to pull that all together. And then as we looked at what we were already doing and how we might how that might benefit we might be able to benefit our patients with the Center for Rare Disease Therapy, we identified a bunch of other things that would be useful. I'm going to talk a little bit about our Plain Communities Clinic and how that came to be. In the last several years, I've been really proselytizing the need to get in front of gene therapy for reasons that we'll come to. And then one of the components that let's see, that we've actually made, I got it. I had the lid on. The thing that we've really been able to, I think, make some nice progress is codifying what we're already doing. So if Pittsburgh is the leading transplant center for metabolic liver disease in the country, and I think in the world still, why is that? What are we doing that makes people want to come to Pittsburgh for their liver transplant? So we put together standard operating procedures that allow us to work from there. And then I'm losing, I can't see it here. Transition from clinical trials to therapy. Clinical trials falls into that land of yeah, it's sort of hard to see. I don't know how to get rid of that bottom piece.
While you're talking.
Clinical trials fall into that in between where it's if you don't participate in clinical trials, you won't have. I don't have too much at the bottom. I try not to use the bottom too much. I'd say. There you go. Okay. And if you're not participating in clinical trials, you're not really at the cutting edge of therapy. So we've developed a huge program working with clinical trials, and then you're ready for bringing it into clinical practice once they're approved. So now we've lost this again. Jeez Louise. Yeah, well, it takes, you got to click back into the slides to get into where it's just terrible. All right, so I mentioned philanthropy here. So funding a CRDT. How do we do that? Well, in the United States, we have this archaic method of funding healthcare, that means you have to pay for it somehow. It doesn't come out of our public coffers. So you can think of a number of ways of doing this. We use the philanthropy. So here we are at a fundraiser with George Meseregas there, our chief of liver transplant, and I happened to be flying out of town for a meeting that day. So my team wanted me to be there, so they managed to find an old picture of me and put it there. There it is. I've talked to some folks who are going the route that is a little easier to do. The hospital or the university says, yeah, this is a good idea. Here's some money to get started. I didn't have that luxury. But then in the long term, what you really have to do is prove your value in some way, shape, or form to the hospital system by bringing in clinical income. And so long term, what that means is you've got to increase your volume. You've got to bring these patients to your clinic, and in a way that is greater than your incremental expenses. There are a bunch of other rare disease related entities out there in the United States that can function as collaborators in the context of a Center for Rare Disease Therapy. Not so much for funding, but just to have a base of individuals who are interested in these sorts of things. The Undiagnosed Disease Network, and I mean, if you're an Undiagnosed Disease Center for the NIH, although the program is subsetting, there was money available for that. Rare Disease Clinical Research Networks, NORD, the National Organization of Rare Diseases, all have programs that can be adjuncts to what you do locally, and NORD has even started rare disease centers of excellence now that are looking to do similar things to what we've done locally with our CRDT. So I mentioned these clinical guidelines or standard operating procedures, and here's an example of one for propionic acidemia and methylmalonic acidemia. Why do we need that? We can all go to the textbooks, right? Well, because the GI docs and the liver docs and the transplant docs don't read the textbooks. They come to us, and if they come to us, what does that mean? Well, we want to be sure that everybody gets high quality and consistent care for target disorders, and you want to be able to standardize clinical care across providers. So it doesn't matter whether they see me or someone else in my division. We all have the same base to work from, but then standardizes things across the other disciplines. So if you go in and look at this, it's got what you do pre-transplant to take care of these patients, so standard inborn errors kind of therapy, but what they need to be ready for transplant, what the anesthesiologists need to do during the operation, how you treat them post-operatively, and then what the long-term follow-up is. And so these are really useful, and we've had a lot of requests for them. We give them out without hesitation, and it doesn't mean that your institution these exact steps will work, but if something's already there, sometimes you can not have to reinvent the wheel to do it. I mentioned our Plain Communities clinic. We call it the Plain Communities Translational Clinic, and it really is an example of how you can adapt a structure like this to a need that was always there, but maybe not being recognized very well. So, the Plain Communities in the United States, this is an Anabaptist movement. It began back in the 16th century in Europe, and they started coming to the U.S. Mostly in the 1700s, but also a lot in the 1800s. And the Old Order Amish are the most prominent in the United States, but there are a lot of them. Pennsylvania, it turns out, has the highest plain communities population in the United States. So it's a lot of what we do, and it's not unusual to walk through our hospital and see plain communities members walking the hallways. It's quite an interesting sight, and in spite of their 17th or 18th century lifestyle, they accept modern medicine. We can walk into the CICU and see kids on plain community kids on ECMO. So we and you had told a lot from about a plain family by their dress, by the configuration of their buggies, even by the color of the roof of their buggies. But one of the things that they all have in common are large families, and I say that as a precursor to the patient that really started us along our plain communities trail. And so this was a 15-year-old. She lived in north of Pittsburgh, and she had a long-standing history of developmental delay, hearing loss, poor growth, poor appetite, decreased in energy compared to her peers. She showed up with altered mental status. She was seizing. She had lactic acidosis. She had basal ganglion strokes. And in retrospect, by history, she'd had a number of these episodes. And it was perfectly obvious what she had. She had MELAS, and we did the testing, and sure enough, they had the common MELAS mutation. But when we went back to talk to them, the genetic counselor who had done the history, the family history, had said, well, no, there's nobody else in the family who has anything like this. But this family had only one child, her. And so a then fellow, now faculty member, got interested in this case, and we said, well, surely this is for those of you who don't know why I'm saying this, it's a mitochondrial DNA mutation. It's inherited from the mother. And so all individuals who were affected come from an affected mother, and only affected mothers can pass it on. So where did hers come from? Well, it turns out that it really wasn't an unaffected pedigree. The family members were all through the UPMC system. They were showing up with diabetes and deafness, the most common manifestation of this mutation. They had kidney transplants. They had recurrent strokes, and no one in the system. And to be fair, we're the only geneticists in the system. There's no adult genetics in the UPMC system. It's us, and they never think to call us. So we documented this across the system, across the family, and we said, well, this is not right. We can't do this. If you look in eastern Pennsylvania, there's the Clinic for Special Children started by Holmes Morton that specializes in treating plain communities individuals. So we said, well, we need to do something. And we didn't need primary care clinics the way Holmes started in Lancaster County, but we did need some coordinated care. So we started our plain communities clinic. And it's now a platform for research in the community, for coordinating care, and we're able to corral families like this and make sure that the appropriate notices there are in their chart about what their underlying disease is. And so it's as I said, it's an example of seeing what's around you. And recognizing it and trying to meet that need. The father of this individual, the young lady who was our proband, said to us at one point, well, we're not as sophisticated as those Eastern Amish. And so our job was a little daunting. I can tell you it's been a success, though, because when I walk into the hospital and introduce myself to an Amish family, Inevitably, what they say to me, "Oh, you're Kate's husband," because my wife coordinates the clinic. And it's fun. It's fun to be identified as that. A legend among the community now. One of their families, the mother of that young lady that I just talked to, she's in the hospital forever. And my wife said, "What's anything you need?" And she goes, "Well, I'm really running out of supplies. I'd like to go to Walmart." So she took her to Walmart. So I will also get, "Oh, you're Kate's husband. No, yeah, he took Betty to Walmart." You know? So that's what you need to do. All right. So this is Sarah. She's a 15-year-old girl. She had this horrible dermatitis, and she'd been in the UPMC system since birth, with no diagnosis. And her chart is filled with, dermatitis. Nobody commented on the fact that she had small stature, microcephaly, congenital cataracts, developmental delay, and an MRI with gliosis. And when she came to me, I said, "Well, small stature, microcephaly, congenital cataracts, developmental delay, and MRI with gliosis. We need to look for this." And I said, "Well, this really looks to me like a disorder in sterol metabolism, and only if you can call this milder." So we did some investigations, and eventually it turned out that this was a new disorder. It's where cursor is right over here. There was some uncertainty in the cholesterol synthesis pathway, and it turns out that we were able to, by identifying her defects, studying the biochemistry, and putting it into this pathway, to redesign and redefine the pathway. So it was a nice basic science kind of thing, but it also gave us some insights as to what might be going on here, because the block behind this step leads to predicted to lead to an increase in methyl sterols, and methyl sterols are very inflammatory. So we looked we did some studies on fibroblasts on her blood, and we showed that in fact she had elevated total methyl sterols and low cholesterol. One of the other characteristics of this pathway. And said, "Okay, so now maybe we have a therapy. Let's supplement with cholesterol and see what happens." Well, nothing really happened. And we said, "All right, so maybe we need something else." We all know how to block entry into this pathway, right? It's statins, HMG-CoA reductase inhibitors, and so we put her on an HMG-CoA reductase inhibitor, and we got a sudden burst of growth. She went into puberty. But we were still having problems with the skin. So here's where having colleagues helps. I went to our clinical pharmacologist, and I said, "Well, how come this isn't improving the skin?" And she said to me, "Oh, well, it's obvious. The skin drugs don't get into skin very well. You got to use a cream." So our pharmacy concocted a cream that was cholesterol and statin mixed together, and she went from that to that. And this was our entry into the world of sterols, and we, as part of our CRDT, joined in an application for a sterol rare disease clinical research network, and we're able to build this into a new area of research and clinical interest for us. Clinical trials, as I mentioned, are really the gateway to the next generation of clinical therapies. So as a CRDT, we've really made it our business to be in clinical trials. When I got to Pittsburgh, there were no clinical trials going on. The university made it very, very difficult to participate. So I had to navigate a whole lot of changes to make this happen. Just to give you an idea, the very first clinical trial I participated in was for Kuvan, sapropterin for PKU. And at the time, it was the only thing going on. This is, as of March 2024, a list of the clinical trials going on for PKU. So it's remarkable. And if you want to be on the cutting edge of treating PKU, and this is true for many other disorders, you really have to participate in clinical trials. I was able to leverage having industry contacts to getting one of the drugs that I was developing in my lab, triheptanoin for fatty acid oxidation disorders, into clinical trials and FDA approved. And it's still the only drug out there for fatty acid oxidation disorders. So it helps in unexpected ways as well as the ways that you're planning. And transitioning from clinical trials to gene therapy is as I'm going to do now, is really an absolutely essential step, because the future of rare disease therapy is going to be in gene therapy. There will always be small molecules out there, but with 10,000 rare diseases, it's just untenable that we're going to be able to have all of know the pathophysiology of all of these things well enough to develop something like triheptanoin, which was based purely on knowing the pathophysiology for every disease there. So why gene therapy? Well, you can get durable expression of a therapeutic gene at a level sufficient to fix a disease. And all you need to know is what the gene is, no matter what the function is. Well, it does, but in theory, you can fix anything. But the therapeutic requirements are pretty stringent. You've got to be able to get it into the relevant tissue, and it's got to be stably expressed. You can't interfere with the functional integrity of the cell, and ideally, it should be permanent. Now, that's not always true, but even if you had to do something, say, once every 10 years, that would really be acceptable for most of these. While the currently approved drugs are fairly limited, although growing, the growth is really predicted to be explosive. And when I talk to my hospital, the thing that I need to emphasize, because I have to, is the financial aspect of this. This is going to disrupt current therapies for rare disease. Why would you spend the money for two ER teams, a lot of very expensive transplant surgeons, more than geneticists, to be able to transplant a patient with a urea cycle defect, propionic acidemia or methylmalonic acidemia, two of the highest levels of highest numbers of patients that we deliver transplants for, when I can just bring them in and sit them in a chair and give them an infusion for an hour and they're fixed with gene therapy. So when I talk to my hospital CEO and I say, look, we're going to put your transplant team out of business, her eyes just go like this, like, oh my goodness, what do you mean? How can this be? Well, it's happening. If you look at the drugs approved by the FDA over the last 10 plus years, over half of them have been drugs for rare diseases, and the majority of those are in the last years have been gene therapies. Now, they haven't really hit genetic disease yet. Most of those are for cancers and CAR T technology. But it's increasing. So if you look at this is a publication by the Society for Cell and Gene Therapy in the United States, and you can see that approved gene, cell, and RNA therapies as of this month, this was released, 32 gene therapies, 28 RNA therapies, and 68 non-genetically modified cell therapies. We're not going to spend too much time talking about what any kind of what those all are. But it's increasing, and the pipeline is almost an open water main. 4,000 therapies in development. Half of those are for rare diseases. And while many of them are, as I mentioned, for cancer, the number for genetic disorders is increasing. Here, from a review that I published was last year, the evolving market is such that by the end of this decade, it's predicted to have somewhere around 30 gene therapies for inborn errors of metabolism or rare genetic diseases, with as many as 50,000 patients treated. When you stop to think that these treatments cost anywhere between $1 million and $4 million, that's a lot of money. So if all I'm going to get for doing that gene therapy is an hour in an infusion chair, how are we going to make this tenable in a system in the United States? It's insurance, in Canada it's your health plan. How are we going to make this? How are we going to recover the money to make this tenable for the hospital? Well, this was anything a genetic disorder that has a gene therapy in development. So it's the incidence of those diseases. So it's the one point in time, how frequent are they in the general population, and then the prevalence is just the buildup across. Still genetic, yeah. This is all genetic. So we're not talking about cancer here. And I think I already said all of this. Except the last bullet was when I go to my hospital and I say, well, here's a risk. Administrators are all about risk and opportunities. So I said, here's what we need to do to take advantage of this. We do a lot of gene therapy trials, or at least whatever's out there. And so I said, look, we've got an infrastructure for this. Let's build a center for gene therapy inside the Center for Rare Disease Therapy that will allow us to leverage what we're doing in clinical trials. These are actually pretty complicated. We had a patient, two patients who had very bad atypical HUS kinds of reactions to one of these gene therapies, and it was pretty dicey taking care of those kids. And so what you want to do is be able to say we can do more than just put this kid in an infusion chair, and we're ready to do that. If you haven't administered one of these, you might not want to set it up and do it right away. But if you're in the forefront of that, you're going to continue to be in the forefront of it. It's how liver transplant came to be in Pittsburgh. They basically started the field of liver transplant with Starzl, and it just they never relinquished their lead. So that's what I want to be able to do for us, and you might want to do it for you. So how does that work? Well, we said it's a 1 hour infusion. Is that gene therapy? Is it just a one-time procedure? You bring them in, you give them the gene therapy, you never see them. Is it a whole system? Who's going to do it, and who's going to pay for it? Well, those are very important questions to start asking now, because the first of these gene therapies has already hit. Metachromatic leukodystrophy was just approved in the United States. So as it turns out, because of this other neurodegenerative center that I mentioned when I started, we have the largest collection of MLD patients in the United States, in the world, really. And the company that made the MLD makes the MLD drug said to us, well, will you refer to one of these other centers, because we're going to just set up a limited number of them? And I just said, no, you're going to set us up as a center. Well, we don't have authority to do that. Get it? And they did. So we're and that's the goal here is by having the experience up front, you can bring these patients to you rather than send them somewhere else. Now, is that a good thing? Well, I don't know. We're gonna figure that out. But before you can even get there, this is a talk for another grand round sometime maybe. Is you got to identify the patient, and for those of you who deal with patients with rare diseases, you know that the diagnostic odyssey of these families as they find get to the real answer for their kids' problems or their own tends to be quite long. There's a 3 to 5 year delay depending on the disease in coming to diagnosis. And as we move more and more into the using a genome sequencing as a primary test rather than a last resort, that time frame is going to drop considerably. And whether you are applying it in the newborn or as an age-appropriate screen, the sooner you identify patients with who need these therapies, the better off they are. So, what is a center for gene therapy look like? Well, it's a system. It's not a clinic. It's not an individual physician. It's not a one-time therapy. You have to be able to scale it to reach the number of patients that are out there. You have to be able to bring a collaboration across the disciplines that are necessary to make sure that the patient is well prior or as well as can be prior to the therapy, and then monitor them during the therapy. There's almost certainly going to be some centralization of this. Not everybody is going to be able to do these therapies. And there's regulation. The FDA in the United States it puts a lot of regulations around how you can use these and what you need to do to how long you need to follow them up and all of those sorts of things. And then gauging the patient populations. Do they really want this? Well, presumably they do, or the companies haven't done their homework. But most families, you say, do you want me to be able to cure your child? The answer is, of course, yes. And then you have to get them in. So what do models of gene therapy look like? They're as variable as they can be as variable as there are institutions. And this is a publication from last year, maybe a couple of years ago, where an NIH conference on rare diseases and rare disease therapy. This was one of the papers that came out of it as a position paper. And this was the working group that I led, and two obvious models here, both working on the assumption that not everybody is going to do everything. So you can have overlapping centers that do different components of it, diagnostic, treatment, follow-up, with some sort of coordinating superstructure, or you can have spoken hub models where there's different centers have different expertise, and patients go to that center for a particular disease. But even if you're not participating in the gene therapy, you probably, as a metabolic center or a geneticist, can follow these individuals, and so you feed into that center, and patients go back and forth depending on the needs. So this is sort of TBD, and will develop almost certainly organically. But I don't see any way that we're going to have anything but a limited number of these centers that are going to do the gene therapies, because it's just the resources involved and the expertise involved and there just aren't enough of us to be everywhere all at once. One of the most important aspects of gene therapy is making sure you've got the right patient. And here's where the diagnosticians, the geneticists, come in. You've got to have not only the right gene, but sometimes the right mutations, because some of these mutations some of these therapies are mutation specific. You have to understand the phenotype, the spectrum of disease, because if you don't know what that natural history is, how are you going to decide whether or not you want to spend $4 million to change it? Are there other therapeutic options? Well, if there are, and they're cheaper than gene therapy and as effective, then we ought to be considering those. A heavy emphasis on making sure that all necessary therapies to take care of the patient are part of this. And that's why I like it as part of our CRDT, because we've already got that cross-divisional, cross-departmental, cross-hospital as interactions established. Patients have to know what they're getting into, the reality of it is not everybody has equal access to healthcare in the United States. How do you make sure that this is being distributed in an equitable and just one of the most important aspects of a center for gene therapy is the educational aspect. You've got to not only the patients have to understand what's going on, but you have to understand. I mean, all of the staff around you have to understand it. So your genetic colleagues, other clinicians, hospital administrators. I'm spending a lot of time trying to convince them that if they don't do this, not only are they going to fall behind the curve in treatment, they're going to lose money. Insurers are interesting, which in the United States with private insurance, you've got to go one insurer at a time and get approval for something like this. And then pulling the team together includes all of the ancillary support. So like pharmacists, if your pharmacists don't know how to handle a gene therapy or an mRNA therapy, then it's difficult. The equity issue is a huge one, and I could spend an hour talking about it, but since I don't have an hour, I'm not going to. It's just we have to get this out to people in an equitable fashion, and a lot of that goes down to something that we've just lost with COVID, which is trust in the field. We have to recapture that, and it allows us to engage communities who are that are underserved and oftentimes more skeptical about these kinds of therapies. Let's look at the financial side of things. I know you don't like to talk about dollars in a public healthcare system, but this comes back to hit you no matter what. So the average bill for a liver transplant, the year surrounding the transplant, this includes a year follow-up, and at Children's in Pittsburgh, $1 million. Gene therapy, not counting the drug. These are actual numbers from our early experience with delivering spinal muscular atrophy gene therapy. $50,000. This is why my hospital administration, their eyes grow big when I say you're going to lose money here. I'm gonna take liver transplants away from you, and they're going to become it's going to become a small potatoes bottom line for us. Average cost of a drug. This is for Zolgensma, $4 million. Ouch! How are we going to make that? How are we going to make that work? Well, so you got to engage your system. In my case, I work about a third of our patients are insured by our own health insurer, UPMC health plan. So I'm talking to them in advance. I'm saying, this is going to come. You're going to get these bills for $4 million. How are you going to handle it? And more importantly, how are you going to make sure that those of us who are doing this have sufficient income to continue to do this, that our hospitals don't say, well, we can't afford you, we're firing you because now you're not, they like me now because I bring lots of referrals in for liver transplant. What happens with, instead of making $1 million, I'm bringing $4 million of charges in drugs? I may be calling you for a job soon, Pranesh. That's just, I may have to. So what I'm working on are reimbursement models, and arguing that gene therapy is not just the delivery of the drug. It's not that 1 hour in the infusion chair. It's an integrated system. It's an integrated model. So you've got to confirm the disease. You've got to ensure that the patient is in optimal shape to get the procedure. Then there's that delivery of the drug. You've got short-term follow-up. You got to know what the complications are of administering a viral therapy or whatever the therapy is. And then longer-term follow-up because ultimately you want to be able to prove to the people who are paying for these things that it's actually worth their while. You know, if I can stop a kid with a urea cycle defect from having a liver transplant and stay healthy, and that only costs $1 million, it saves money for over the life of that patient. The problem in the U.S. system is my health insurance says, but who cares? That family statistically is going to move in 5 years. So I will have paid the $5 million to get the therapy, and the next health system down the road gets all the benefit from it. Never mind that some people move to Pittsburgh, but that's another story. So I'm using this harebrained idea. I say, look, you should be willing to pay me 10% of what that drug costs to make sure that that $4 million drug is used properly. We'll see. They actually kind of like the idea, though they think 10% might be a little high. Like, okay, give me 5. I don't care. Let's just codify this so that we make it reasonable. So to finish up, what you need to start a Center for Rare Disease Therapy is not much different than you're used to for any other clinical enterprise. You need staff, and you know, depending on whether or not you make gene therapy a focus, that will differ. And especially as I mentioned, the pharmacy facilities. You ideally have an integrated clinic and office space so that there's some feeling of a true center. Virtual centers, like virtual grand rounds, have their purposes, but there's nothing like being in the same place at the same time to build the rapport that's so valuable for all of us to feel like we're making a difference. Somebody's got to pay for this, so you've got to work in advance with your providers or your insurers, and then if in fact there's going to be a limited number of centers doing this, you want to be a little bit greedy. You want to attract them to you rather than to the center in the next state or province. And so much like our liver transplant patients, I want national and international patients to come to Pittsburgh to get gene therapy because they know what they're doing and they've done it a lot. And there's some dollar investment here, but in fact, it actually turns out to be not so great. I've been living for the last 5 years or so for our center expenses on a fundraiser that our foundation held for us. They have a once a year gala that they designate a particular focus, and they one year they were kind enough to highlight us, and we got about $750,000 from that effort. And it's been enough to keep us going. I was just at the University of Michigan, and they're doing they're looking at a similar program, and they're asking their institution to give them $50 million to get started. I don't know where you guys stand. It's going to probably not. All right, there we go. What are our next steps? Well, our trainers have to be comfortable doing this. Medical genetics doesn't have a focus in their training curriculum on gene therapy, and in fact, it's not a whole lot on therapy at all in there. And a bunch of us have gotten together and published a position paper that the American Board of Medical Genetics and Genomics should include gene therapy as a core competency in a medical genetics residency. We need to sell genetics to our medical students to get them to come into our discipline. Because if we get 10,000 rare diseases and a gene therapy for even 1% of them, we're all going to be overwhelmed. And then the materials that you need to help train other disciplines. So I don't think I'm going to spend time on this. Gene therapy's here, and it's going to be the global here and local here. It's going to be here soon. You know, you're going to have to figure out how to deal with these. It takes as much common sense as it does dollars, and getting hospital administrators who I hope don't listen to this because I've been disparaging them a little bit to understand common sense is sometimes a hard sell. There's the homepage for our Center for Rare Disease Therapy, and one of my first patients treated with triheptanone and her mom picked her up when she was 3, and she's going to college. I feel like I'm getting old, but it's worth it. You gotta do it. It's my lab and my clinical research team. And it looks like that's all I got. I thought I had a picture of us, my family, kayaking the last time I was up to one of these meetings in the Bay of Fundy. It was great. It's a great thing. But let's get out of there. I don't think I need to. We can stop the sharing. And I'm happy to take questions.
Great, thank you. Yeah. You mentioned talking about this kind of an invite program, so you may have people listening in.
Didn't disparage government. You know.
Branish, we can't hear you. I don't think, at least I can't.
Yeah. Sorry, Leanne, can you hear me now?
I can. You sound great. Your usual great self now.
Thanks. It's a directional mic. So yeah, I mean, one thing I shared was the, since we started screening for SMA in Ontario 4 years ago, it's 45 kids who are now going to walk or are walking.
Mm-hmm.
And
remarkable, actually.
It's remarkable, right? And this is just the edge, right? So one question I had before we go to Leanne's question was, I think a lot of these drugs and therapies and gene therapies are going to need to be secondary preventative treatment. You mentioned screening, and I'm trying to think of the diseases where you're not going to need to screen.
So, like I said, that's not a grand rounds, what we're headed for is genome-based newborn screening. There's no other way to do it. With all of its problems and its warts, it's the only way you're going to identify most of these disorders in a time frame that allows you to get in there and treat them before symptoms develop, which is what you need for most of these. It's not as bad as it sounds because you're not gonna do unblinded whole genome sequencing on every baby and give them the story of their lives in advance. If you look, for example, at the approach that the San Diego group is taking, Stephen Kingsmore, it's to do a targeted genome analysis on a couple of hundred diseases that have a significant clinical impact in the first year of life. And I think we're actually ready to handle that from a newborn screening standpoint. It requires a new way of thinking, but I think it is doable. But then you have a genome sequence that now when a kid develops a symptom that you didn't expect, or you don't know what's going on at age 3, you can go back and interrogate the genome. And you can even say, well, at a year, everybody does a hematocrit to look for anemia in a baby. Why not at a year, or at 5 years, or at 10 years, or even 50 years, you look at the genome and say, what's your risk for the next interval of period?
Leanne, did you still have your question? And then we have Chris.
Yeah, I do actually. Thank you so much for that. It's really great. I'm sure Dr. Chakraborty has told you that your Grand Rounds is incredibly timely with the Canadian Rare Disease Network starting up and the investment in the federal government in rare in Canada, including therapeutic trials. I just want to just ask you, I really appreciated your comment about the fact that when you do therapeutic trials, gene therapy or even biology targeted therapy, that you need to move from a physician-driven model to a system-driven model. And we're not there yet. We are a physician-driven therapeutic trials landscape at CHEO. And I know that there's interest in moving it to a system-based model. And I was just wondering what your advice would be to the CHEO community as we think about how we can better integrate therapeutic clinical trials into the clinical care landscape. And before you answer, I'll just say one more thing, and it's really for my CHEO colleagues, if I may, if you give me 1 second. I think people have to understand that when children come to see us for research, 75% of what we do with that child and that family emulates what we do as part of routine clinical care. We're caring for the child at that visit. And then there's a portion of that visit that is dictated by the protocol and the novel therapy, but we're really giving care and we don't ignore the things they need at the time of that research visit that might be out of the scope of research. So I'll put that back to you in terms of how we go from a physician-driven to a system or institutionally driven research landscape for therapeutic trials.
I'll let you know when I figure it out. No, I think you build the team first, and then you figure out how it becomes institutionalized. And my clinical research team functions almost completely independently of me on a day-to-day basis. I go to see a patient, and that's most of my input. A new trial comes up, I review the protocol, it looks good. The institution then takes over and negotiates all of the vagaries of budget and funding and all of that. So it's going to be institutional specific is I guess what I'm saying. But you're right. It's the point that I made that this is not an individual, but it is a system, and you have to accommodate all aspects of that system before you can really be an effective clinical trials group, because otherwise, you can do 1 or 2 or 3 or 4. We probably have 30 clinical trials going on right now, and I probably have 60 or 70 IRB protocols that I have to juggle, and that doesn't work with a me-centric kind of approach. It is a system.
Thank you.
Great, thanks. And we're over time, but Christian, if you can ask, then we'll call it a day after.
I'm sorry, I can't hear if you're asking me if my question's ready.
Yes, go ahead.
Oh, thanks very much. My name's Chris Scott. I've recently come here from South Africa, so my perspective is going to ask you about global health perspectives on the costs of these therapies. As you know, the majority of the world's children actually live in places where these drugs are unaffordable, and it's estimated that by 2050, 4 out of every 5 children will either live in Africa or Asia. And you know that as well, the drug policies have favored the development of these orphan drugs recently, and that's been good. But as these drugs are coming into the pipeline one by one, the prices are just exorbitant. And it always strikes me that we just accept the prices as the price of the drug as a fixed point in our engagement with this whole thing. And so my question is, on a global health sort of scale, do you foresee, and I want you to speculate, do you foresee downward pressure on the prices? Do you foresee that the technology will become such that it'll be more accessible to people in less resourced areas, or is this going to remain something that is only within the reach of the most wealthy healthcare systems in the most healthy countries? Because even most public health based countries will balk at this kind of price. And to add just a little flavor to that, as well as many of these trials for these agents are happening in less resourced countries. For instance, Zolgensma is being trialed in South Africa as well. But I know that when the marketing happens, it's not going to be available to people in Africa. So how do you see that all playing out in the global health equity scene?
Well, all I can say is that the current system is untenable. It's going to explode or implode, whichever direction you want to call it. We can't continue to have these drugs be $1 and $3 and $4 million. How is that going to change? Well, surely technology will change. The FDA is already trying to wrestle with the idea of sort of platform development. If you use the same vector backbone and you put 20 different inserts into it to treat 20 different diseases, is that a different drug? Do you need the same kind of resources to get it approved as you do a single drug? And so I think the regulatory, we have to start with the regulatory side of things and say that's got to change. And then I'm a glass half full, sometimes a tenth full kind of guy, and I say that technology is going to rescue us. It always has. There's no reason to think it won't. But sometimes, so things will get cheaper to make. Somebody will come up with the next breakthrough that makes that happen. Does it mean it's going to be painless? No, I think it's going to be painful, and I think there's going to be a period of time where we're stuck making hard decisions about, do we put money into vaccines in underserved areas of the world, or do we treat rare disease in more developed countries? And fortunately, I end up saying, look, that's way above my pay grade. I'm gonna do what I can and play in the system the role that I can, and make sure that choices are available while the system catches up to those choices.
Thank you.
Yeah, thanks, Jerry, and thanks people for those questions. For anyone who is on site, we're going to follow this up with an hour and a half of time with some coffee in the RI2 third floor boardroom. For anyone who's interested in continuing the conversation with Jerry and just brainstorming a bit, please feel free to join us there. And with that, I'd like to thank Jerry for taking an extra day out of his schedule to come join us at CHEO, and thank him for his talk.
Thanks.
Not